Hello and good afternoon. Thanks for joining us at this afternoon's telehealth webinar. Today, we're going to be talking about transforming rural healthcare through remote patient monitoring. This afternoon, we have Kara Massa, who's the Director of Clinical Programs with HIGI. She is that is a motive care service. Kara is going to share some insights into the Michigan Center for Rural Health's enhancing remote patient monitoring and three independent rural critical access hospitals. Um, I will now turn this over to Kara.
Awesome. Thank you, Amanda. Good afternoon, everyone. So excited to spend some time with you this afternoon and just welcoming any questions along the way. So please put them in the chat. I know Amanda will help me stay on top of the chat. And all interruptions welcome. Want to make sure we're all on the same page as we chug along. But I'm just really ecstatic to talk with everyone about the power of remote patient monitoring and specifically the work that the Michigan Center for Rural Health has championed with three outstanding rural independent partner hospitals over the course of the last 18 months. Before we jump in to the presentation, again, please ask questions. I believe this will be made into a resource that can be accessed after our time together. So if you hear something that you want to share with others, I think that'll be possible for you. And as Amanda kindly shared, my name is Kara Massa. I'm a proud member of the HIGI and broader Motive Care team. HIGI is just one piece of the larger Motive Care organization, which provides integrated supportive care services which enable access to care while addressing health-related social needs. The member or patient is at the center of everything we do. And a very large chunk of the broader Motive Care business focuses on meeting the supportive care needs of Medicare and Medicaid members across the U.S. Through our non-emergency medical transportation services, personal care, digital engagement, and monitoring services. And today, I'm really excited to focus in on one aspect of our monitoring suite of services, specifically our remote patient monitoring service, HIGI Care Every Day. But first, before we jump into talking all about the pilot that took place over the course of the last 18 months here in Michigan, I just want to make sure we're all on the same page when it comes to what is remote patient monitoring. So just have a few slides to kind of set the groundwork here before we dive into learning more about the pilot. So specifically RPM, or sometimes called remote physiological monitoring, remote patient monitoring. It's a form of telehealth that typically supports primary care teams with assisting patients in effectively managing their medical conditions through the use of medical devices outside the traditional four walls of conventional healthcare settings. Now, these devices capture physiological biometric readings that are electronically transmitted to a clinician and monitored in between a patient's regular office visits. RPM devices, they must meet the Food and Drug Administration's criteria for a designated medical device, so that's good to note. And this non-face-to-face monitoring and analysis of physiological factors used to understand a patient's health status is a proactive way to monitor a patient's health in the hopes of identifying and intervening. Some of the biometric data that can be captured through RPM devices includes blood pressure, blood glucose, body weight, heart rate, oxygen saturation, and these various devices can be used in conjunction with one another. RPM, it's not its first time around the block, although it's gained more attention over the last few years, especially since 2020 and the initial onset of the COVID-19 pandemic. Clinical evidence supporting the use of RPM has been around for 2+ decades. COVID definitely accelerated the reach of RPM, just as it gave a big boost to all aspects of telehealth. And as you can see here on the bottom of the screen, studies continue to demonstrate the clinical benefits of RPM. And just as the body of evidence continues to grow, so too do the various use cases for RPM, which is exciting. In terms of kind of high level benefits of remote patient monitoring, it definitely has the potential to be an extremely powerful tool that, if done right, can aid organizations in their quest to achieve the quadruple aim, which who doesn't love that? And here on the screen, you'll just see a few of the common benefits of RPM. And above and beyond some of these major benefits, such as cost avoidance for patients and healthcare organizations, additional benefits of RPM can include, increased medication adherence, improved quality measures, gap closure, more meaningful patient provider encounters with that additional layer of insight that RPM provides. The ability to leverage data to uncover better population health insights, improved operational efficiencies for providers and practices. So, a lot of fabulous benefits. But knowing so many of us are really invested in our rural areas, especially here in the state of Michigan, RPM benefits can really be amplified in rural settings. So, just wanted to kind of do a double click into that. Um, because of the various dynamics that are in play in rural settings versus urban settings. So, from peace of mind impacts to literally removing barriers, such as the need for transportation for certain patient touch points, RPM can be a game changer for many who live in rural America. And just as the potential benefits of RPM can be amplified in rural setting, so too can the potential barriers. Whenever I think about this, I always think you take the good, you take the bad, and then you have the facts of life. So um, just focusing back on potential barriers in rural settings, here on the screen, we do have some items that can certainly be amplified or heightened given external factors. Connectivity, of course, meaning device connectivity, that's such a critical component of device readings. Being able to have those devices readily send the data in real time. Of course, staffing and resources can rear itself as a barrier. And working with rural populations and specifically with senior citizens in rural environments, often technology literacy and acceptance are always something that you're dealing with. And then similar to the resourcing piece, financial constraints, especially in the healthcare landscape, is something I think we all are more than familiar with, whether we like it or not. Trust, I always love to highlight this one. Trust is an interesting one. Often, trust in rural communities is something that has been fostered over many years, if not, possibly even generations. And anytime you're introducing something new, whether it be associated with new people or not, new can take a while to warm up to. I think we're all very familiar with that. And new can be different, new can be hard, different can be hard. So that's something definitely to keep in mind as a potential barrier when bringing RPM into a rural setting. And then finally, a barrier that may need to be addressed with RPM coming into play here are various stakeholders may have the belief that RPM and CCM, chronic care management, maybe those offerings can't play nicely together in the sandbox, which is not the case, which is really fantastic. And we'll talk a little bit more about that in depth as we get into discussion about the pilot. One last thing I'll touch on before we keep moving here is this is just kind of a hot off the press article. It was originally published late last year, but then just featured a few months ago in the February issue of the American Journal of Hypertension. And data continues to show, although COVID did a lot for expanding telehealth services and expediting the utilization of such services, specifically when focusing on rural settings, the data demonstrated that rural residents were less likely to use telehealth for hypertension management. And when our team saw this in February, it really reinforced for us what we have been living and breathing with rural Michiganders. However, that is not to say there are not ways to mitigate this issue. So as we break down the RPM pilot, I'm excited to share ways in which we were able to overcome this barrier by pulling various levers. Specifically, one crucial way to help overcome this trend in hypertension is specifically the partnership with a RPM patient's primary care provider. When patients hear directly from their trusted provider that RPM is something they are prescribing per se to the patient, and the patient hears that reinforcement through the various PCP interactions, the value, they like to hear from their PCP the value of the data and how that helps create a personalized care plan for that patient. And so that really moves the dial. We have found with patients in rural settings is that connection between the PCP valuing the RPM data, leveraging it to create a more personalized health plan for the patient, because we know primary care providers are such a trusted resource for many folks, especially those in rural settings. So I'll pause there really quickly. If any questions related just to RPM in general, please feel free to pop those into the chat. And before we break down what we did exactly over the course of the 18-month pilot, I just want to touch on maybe two more quick industry things, and then also how the RPM program that we implemented is set up, just so everybody can get their bearings. There is one less barrier for RPM today in rural settings, which is really huge. So for those of you not aware, that prior to January 1st of this year, rural health clinics and FQHCs, if they wanted to implement RPM, they could, however, they could not be reimbursed for it. So that creates quite a challenge. Luckily, with the maturation of RPM billing codes as of January 1, 2024, FQHCs and RHCs can now bill for RPM services. So that is an extremely welcome change for rural communities throughout the country. Prior to 2024, if you had a FQHC or rural health clinic who wanted to provide RPM services, they had to work with an external RPM vendor if they wanted the services to be billed in some way, shape, or form. So now that that billing barrier has been removed, if desired, FQHCs and RHCs can implement a fully internal RPM program and receive payment for RPM outside of the FQHC per visit payments and RHC all-inclusive rates. So that is a big bombshell in the RPM world and a very welcome change. So we won't spend too much time going in depth on this, but I just wanted to make sure to bring this to everyone's attention. And whenever I think about this, I just think, ding dong, the witch is dead. It was a long time coming, and so grateful that now these organizations have the ability to bill for remote patient monitoring. Industry trends. RPM, it's not going anywhere. However, the innovation will continue. And the more we see healthcare shift to value-based care, the greater the demand for RPM services will become. Use cases, like I mentioned at the top of the hour, they continue to evolve, as well as outcome research. We're seeing more and more. And expanding provider shortages can be partially addressed by digital engagement tools such as RPM. So who doesn't love that? Right. All right. So the 18-month pilot, which I'm so excited to talk to you about, Higgy, the organization I'm with, has been engaged with the Michigan Center for Rural Health and several fabulous rural independent hospitals here in Michigan. But I think it's important just first to understand the RPM solution that we implemented as part of the pilot. Before we talk about, outcomes and all the exciting stuff tied to it. One thing just right off the bat, I think it's helpful to understand the Higgy Care Everyday RPM solution, which we deployed for the pilot. This is, of course, technology enabled, but it's really driven by the relationships and trust our team works so hard to establish, foster, grow. With a keen sense or keen focus on building and maintaining relationships to drive healthy outcomes. and reduce the cost of care, our Higgy clinicians have the goal of improving patient health through proactive identification and response to health concerns before they get out of hand. Our team of clinicians provide care for patients enrolled in RPM in between their traditional doctor appointments. And by staying connected with patients and serving as an extension of their PCP teams, we do that through deployed technology as well as regular patient nurse care manager touch points. And we're really focused on keeping patients with chronic conditions safe and healthy at home. So through our close connection with enrolled patients, we are also afforded the opportunity to screen for social drivers of health on an ongoing basis, which is another huge win. Our Higgy RPM program provides patients with the tools they need to be successful: medical devices, medication accountability, regular care management, and custom medication-specific education, all in an effort to improve care plan adherence and promote positive behavior change as a complement to their patient's current care team and care plan. One last thing I'll just highlight about the solution is that the program was really built in a way that is extremely mindful of clinicians and all they have on their plate right now. We are hypersensitive of how our program impacts clinicians and have had great success in providing our service in a way which serves to lessen the clinical burden of the primary care teams we're partnering with, which is super important because anybody who knows a clinician, they know the last thing they need is more work. So we really want to be mindful of how we partner with providers. And poor Amanda, she's heard me say this so many times that she probably, yeah. Maybe we should get a tattoo of it. I'm not sure, but not all RPM solutions are created equal. And at Higgy, we're very proud of our relationship-driven approach. And by placing patients at the center of their care, we've been able to achieve some exciting outcomes. I just really want to highlight that relationship-driven approach. You remember one of the barriers we talked about is trust, especially in rural communities. And we have found that by putting the patient first and really working to establish a nice relationship with patients, it has allowed us to achieve some really exciting outcomes. Now, it does take an investment to get those relationships up and running, but we're not afraid of a little hard work. And so just want to call out that relationship-driven approach to RPM we find is really impactful when you're dealing with rural residents. So our goal is to catch any health or health-related social issues before they deteriorate so we can keep patients out of the hospital. We personalize and really humanize medicine and deliver kind of that concierge care at little to no cost. So you might be thinking, okay, this all sounds good, but how the heck do you actually do that? So here is just kind of a high-level solution process overview. First and foremost, I want to make sure it's really clear. We at the RPM program, we do not replace a patient's current PCP or their current care manager. Our network relies on board-certified clinicians who enable clinical intervention when it's needed most and act as an extension of the PCP team, the patient's PCP team. Actionable data is shared with treating providers to ensure quick identification of next best actions. So we often, when we're partnering with providers, we like them to think of us as kind of their RPM department. So we're just really there to amplify and augment the great work that the PCPs are already doing with their patients by giving them that kind of extra layer of information about their patient. So if you look up here at the top, first we work with our partner organizations to identify patients. That's typically done through direct referrals or eligibility files, and we'll talk a little bit more about that later and how we handled it with the pilot. Once a patient is identified, Higgy really jumps into action from there and does the heavy lifting. We reach out to the patient to educate them on the program and to onboard them. The process of getting a patient onboarded, it does include an initial telehealth provider visit with one of our Higgy providers. We need to do that to ensure medical necessity, as well as to get to know the patient a bit better and determine their unique needs. And this is also the point then where the appropriate device or devices are ordered and delivered to the patient. From there, a new patient is designated a dedicated registered nurse care manager from the Higgy team. And this care manager works closely with the patient on an ongoing basis to monitor their physiological data and personalized care plan, as well as to provide ongoing care management focused specifically on aspects of the patient's care that can move the needle on their chronic conditions. All along this process, Higgy collaborates closely with the patient's PCP team. And before we move on to the next section of our journey together today and talk about the RPM pilot, I want to highlight for you two important aspects of Higgy Care Everyday's collaboration with the patient's primary care team. And one of them here, this slide demonstrates how we work with partner providers to help avoid unscheduled care. At the top of this slide, you'll see really that our goal, as I stated before, amplify and augment the fantastic work that PCPs are already championing in their community. And we are able to flex our workflows to best meet the needs of our partner organizations. So where providers and partner organizations already have robust care management relationships, we're able to plug into that, not duplicate any of their services, but really serve as a resource not only for their care managers, but then also for their PCPs. Here, this shows kind of how a patient escalation could work when working with a partner organization. First, if a patient escalation is required, our team immediately clinically validates that data. So the registered nurse care managers are getting a hold of the patient, making sure it is a valid situation. If it's determined from there that additional intervention is warranted, our team reaches out to the appropriate contact at the partner organization, whether that be the primary care provider's nurse, or maybe the patient is already working with a care manager at their local healthcare organization. We'll reach out to that care manager, make them aware of the situation, and give them all the data they need to make informed actions. We give them that information. First up, we automatically give a call to the appropriate contact, and then we follow it up with a written escalation report as well. And then from there, we make sure to follow up to find out what the PCP, how they want to modify the care plan for that patient. So then we can help support and implement those recommendations for the patient. Actually, just literally this morning, I was seeing that one of our patients has, over the last 2 weeks, I think he gained like approximately 10 pounds. And he had his monthly touch base this morning. The nurse care manager moved it up a little bit because she'd been watching him. Reached out to him. He started sharing, yeah, my legs are looking a bit swollen. He also talked a little bit about chest tightness. And right away, she said, we've got an issue. So she hung up, immediately called the PCP office. I just heard that he's going to have a 3:30 appointment this afternoon. Of course, he knows if things deteriorate, get to the emergency room, but they were really appreciative for getting a heads up so that hopefully we can get him the right care at the right time without him having to end up in emergency department. So that's just kind of an example of things we see every day where we're able to raise a flag up the flagpole and say, hey, partnering PCP, we think this this individual needs some of your time and attention. So that's fabulous. We also, again, we provide reports based on how the patient is doing to the PCP. We've got monthly summary reports that get sent over. And then also, of course, if there's an escalation report that happens throughout the month, those are sent in real time. But we just really try to make sure that the PCPs have the information they need, so that they have a better sight lines into how their patients are faring in between their traditional visits, which may happen, once every 6 months, once a year, once every 3 months. So those are helpful tools for the PCP. All right, we've officially reached the time of transitioning to talking about everything about our Michigan pilot, which is awesome. So if you've got any questions about anything we've already talked about, put them in the chat and I will make sure to answer those. But okay, so let's talk about what we've been up to with our valued partners, of course, at the Michigan Center for Rural Health, as well as our friends in Sandusky, Manistee, and Newberry. And so to bring you up to speed, back in the summer of 2022, a mutual partner of Michigan Center for Rural Health and Higgy, who happens to be MSU Healthcare, they introduced our organizations and sparks flew. And I might be being a little dramatic. I wasn't actually there to witness the sparks as I was out on maternity leave, but I imagine it was love at first sight. And Michigan Center for Rural Health was looking for a partner to help bring RPM to rural independent hospitals to improve access to care for older rural residents. And MCRH had been invited by the Michigan Health Endowment Fund to apply for an exciting grant, their Special Projects and Emerging Ideas grant. In November of 2022, we heard word that the project had been funded, and that brought us to the beginning of our 18-month pilot journey. So along with the teams at Helen Newberry Joy Hospital, Schoolcraft Memorial Hospital, and Mackenzie Health System, we set out to serve members of their senior populations who had been diagnosed with either hypertension, type 2 diabetes, and/or congestive heart failure, and also who had Medicare Part B as their primary insurance. And so that's kind of how we got our arms around a patient population for the pilot. As you can see here on the screen, we had three main goals. Of course, we wanted to increase access to care in the pilot communities, while also avoiding any additional burden to their local clinicians. We wanted to improve health outcomes for seniors. And then finally, we wanted to document the heck out of everything we did and develop a rural health RPM playbook that could be shared across the state and possibly even beyond, with rural independent organizations interested in learning more about implementing an RPM program for their patient population. And we'll talk a little bit more about that playbook here at the end of our time together. By choosing to bring in Higgy, a third party with RPM expertise, the pilot site organizations did not have to invest in procuring the many resources that are required to internally run an RPM program. So didn't have to hire the necessary staff, invest in softwares, all of that fun stuff that takes time and money. So we started way back when, and really truly in late January of 2023 is when we got off to the races. And then we just formally wrapped the pilot at the end of June. So how many patients did we have in the pilot? Well, we closed our enrollment period when we hit 70 patients enrolled. And up here, I've got some conversion rates for you. Historically, I think it's helpful to understand that when partnering with PCPs who have directly referred patients to Higgy Care Every Day for RPM, our conversion rates typically have been between 25 and 35%, meaning 25 to 30% of referred patients have gone on to enroll in Higgy Care Every Day. And so those are where we kind of have those benchmark numbers. However, when it came to the pilot, we had two of the three organizations who referred patients to the RPM program either through a direct provider referral or through their care management team, their local care management team. And when we look at the conversion rates for that patient population here in the middle of the screen, and we narrow it down to the eligible patients referred. So eligible meaning they qualified medically, they'd been diagnosed with one of the three diagnoses that we needed to have and had Medicare Part B. The conversion rate we saw for enrolling these patients was 48.7%. To say my socks could have been blown off would be an understatement. It was super exciting, and I'll talk about why we think we achieved that strong number here momentarily. And then we had one pilot site where, due to the all familiar barriers of limited resources, which I think hits home for a lot of folks, we took a different approach. Instead of direct patient referrals, Higgy did an outbound phone campaign on behalf of the partner organization based upon an eligibility file to enroll patients in the pilot program. So, as you can see on the far end of the page here, the conversion rate for this approach of, tackling patient enrollment was less successful than if a patient heard about the program through a referral from their PCP or their local care manager. And we came in with just shy of 6.5% with a conversion rate, as opposed to, close to 50%. So we had 70 patients enrolled during the course of the pilot. We did have a few folks disenroll. We had 18 patients disenroll, so attrition was pretty low. The primary cause of disenrollment you'll see here was not lack of patient interest, but rather changes in a patient's insurance coverage to out-of-network providers for whom the service was no longer covered. So due to financial pieces, they determined they would no longer continue on with the program. And then the second most frequent cause, and highlights kind of the really potential for meaningful health impacts here, is when we had a patient who passed away, which of course is always heartbreaking for everybody involved. And just, I can't help but think, we always think, if only we could have worked with them, earlier on in their journey, maybe we could have helped add precious days with their loved ones. So one thing I'm going to just kind of talk about when we go back to that financial concern, patient cost share can impact enrollment levels for patients with few financial resources. I mean, that totally makes sense. Out of the 278 patients who declined to participate in the pilot, only 8 of those individuals outlined that their reason for decline was due to financial reasons. Now, we have reason to believe that at least a subset of those patients who declined, the 252 patients who declined the program due to lack of interest, may very well have seen a potential out-of-pocket patient responsibility as a barrier, and thus provided us the answer of, I'm just not interested, as a way to not share any further information about their situation. So I just wanted to highlight that we thought those who were telling us it's because of financial reason, that number was pretty understated, versus why we thought other people who were saying they just weren't interested were saying we think it was tied to probably the financial commitment, if they had any. Okay, so let's talk about outcomes. As a lot of patients, they had 2 devices. So they may have either had a glucometer and a weight scale, or a blood pressure monitor and a weight scale. You'll find that's very common in RPM with folks with different comorbidities. Usually we don't all too often have a patient with just one device. Typically, we see patients with 2 devices. And I'll buzz through this slide here, but these are some of the improved medical management items that were documented along the journey. So, of course, increased patient engagement, medication adherence, medication adjustment facilitation, enhanced coordination of care, all really important things for patients. So let's talk blood pressure. We here are looking at a slide that relates to our 6-month blood pressure cohort. So out of the 70 patients enrolled, we had 46 patients who had at least 6 months worth of blood pressure readings and active engagement. As you can see from this graph, upon enrolling in the program, 61% of the patients in this cohort had an initial blood pressure reading above HEDIS control, or, another way to say it is 61% of the patients in this cohort had uncontrolled blood pressure. Fast forward to these patients having been enrolled in the Higgy Care Everyday RPM program, and only 22% of patients remained in this uncontrolled state. Or said another way, we saw a 100% increase in population under HEDIS control. Wow, wow, wee, whoa, I like to say. I mean, can we get a heck yeah? It is so exciting to see what a difference RPM can have in the lives of patients. And so, not only from taking their blood pressure regularly, but having that dedicated care manager to coach them through the tough days, to help send them maybe a little something they can hang up in their kitchen, reminding them of the six saltiest foods that, we should try to avoid. Just really that patient education and helping empower patients to get in the driver's seat when it comes to their health. So, blood pressure was awesome to watch. Here, I'm just even kind of doing a double click. So if we break it down to the patients who upon enrollment initially had uncontrolled blood pressure, our sample size comes down to 28 patients. So when we're still looking at that cohort, that 6-month cohort, 28 of those patients initially had uncontrolled blood pressure at the start of the pilot. This graph demonstrates the remarkable improvement among the most vulnerable and targeted population. Not only were these patients brought back into HEDIS compliant range, but their improvement was so significant. And you'll see, an average systolic reduction of 27 millimeters of mercury and an average diastolic reduction of 11 millimeters of mercury, that they ended the program in a categorically normal range of less than, the 120/80 standard. Wow. As we know, 5 millimeters of mercury drop in a systolic blood pressure reduces the risk of major cardiovascular event by 10%. And here, this subset of the 6-month cohort who averaged a systolic blood pressure decrease of 27 millimeters of mercury, the benefits to individual well-being and the broader healthcare expenditure from this improvement, I really feel strongly that it cannot be overstated. This is like what puts the fire underneath our team when we see these outcomes of every call we're making, every alert we're checking is really making a difference for these patients. And then just kind of taking one more step back to talk about that 6-month cohort for blood pressure again. So those 46 patients, even when you include the patients who maybe started, under, HEDIS control, we still saw significant reductions in blood pressure, even when you include those patients who didn't have maybe as much movement to make to get their blood pressure into a really great spot. So this graph represents improvement across the entire population of patients who were continuously engaged for 6 months, including those who had blood pressure when they started, which, both controlled and uncontrolled. So, I mean, these patients dramatically were decreasing their risk of any major cardiovascular event by more than 20% for this entire cohort, which is exciting. So along with blood pressure, we also want to talk about blood glucose. Now, we had a smaller cohort of patients who were monitoring their blood glucose for at least 6 months. That sample size came down to 17 patients, so we recognize that's a bit smaller. And HEDIS blood glucose measures focus on hemoglobin A1C, as we know, which obviously a lab test, and it reveals kind of longer term averages as opposed to the fluctuating instantaneous blood glucose, which typically is measured via glucometry, which we did here in the pilot. So if you look at this graph, the horizontal line that you're looking at 154 milligrams per deciliter, that's the correlation between the A1C hemoglobin of 7 and then that average milligrams per deciliter. So as you can see, our population of 17 patients, They were able to achieve HEDIS compliant blood glucose control within the first month of the program. And then, most importantly, they were able to maintain this control for the duration of the program, which, it's great to make some first early changes, but then I think we all know sticking with those changes can be really challenging. And the patients did a fantastic job of really buckling up and joining the ride. Here we've got one more focusing on blood glucose trends. Oh, sorry, I just added to the right side of the slide. I wanted to highlight two quick stories for you all. So, we had one 64-year-old female. She was in the program for 8 months. She did about 26 readings per month. Her final reduction in blood glucose was averaging 105 milligrams per deciliter. We had another friend, 69-year-old male. He was in the program for 9 months, average of 22 readings per month, and he too saw a significant reduction in his blood glucose. So it's just really cool to bring this down to the patient level and see what a change RPM can help facilitate for patients. The final clinical outcome that I just really want to highlight has to do with weight. So 46 patients had weight scales issued to them as part of the pilot. 70% of patients issued weight scales lost weight during their time in the program. And I have to be honest with you, we were a bit surprised about that. Of course, we're talking about, getting up and moving and, the foods you're eating, all of that good stuff. But obesity isn't like the number one thing that we're, dialed in on. And so when we got back to the 70%, we thought, whoa, baby, is that exciting or what? And when you look at it a bit more closely, so 31 patients of those who had weight scales had that 6 month of continuous reading and active engagement. Out of that cohort of 31 patients, patients lost an average of 4 pounds within 6 months, and then lost an average of 8 pounds throughout the total time in the program, which could have ranged, from 6 to 11 months. But we saw the average time of this cohort was 8.2 months. And then I thought I'd highlight two more stories from friends about some really amazing weight loss. We have one gentleman, 68-year-old male. He was active for 10 months in the program. At 6 months, he hadn't even lost a full pound. But I think this was a testament to the relationship that was built, becoming more comfortable, kind of getting on board. And after 6 months, he just kind of said, I'm going to really put myself into this. And he was able to lose 33 pounds. Now, I will highlight this gentleman. He definitely had a lot of room to move when it came to his weight, and he still has a ways to go yet. But just kind of seeing that finally click for a patient and saying, I'm going to do this is super exciting. We also had 77-year-old female, active for 8 months. At 6 months, the first 6 months, just going after it, she got to 24 pounds loss, and then she kept the weight off. At the 10-month mark, she was at 27 pounds loss. So really exciting to see patients make changes, but also stick with the changes. And again, kind of that accountability of having their nurse care manager checking in with them, encouraging them, providing them resources along the way really makes a difference. When we look at patient satisfaction, so we talked to the patients. Out of the 70 patients enrolled, we were able to get a hold of 47 of them. We didn't reach out for a patient satisfaction survey until the patient had been enrolled for at least 60 days. And then we would try to just get them on the phone for a quick 3-minute phone conversation. We talked to 47 of them. 45 said, yep, let me do the survey. And you can see here that we had some really strong satisfaction scores. And this is not unique. We see this in really all of our relationships. Patients love, especially when you're dealing with seniors who maybe some of them can't get out of the house too often, maybe have a smaller social circle. patients really get excited to talk to their nurse care manager, and it makes a difference in their lives. So you'll see here they wanted to recommend us. Device ease of use average score was really high. And then also their interactions, not only with our providers during that initial telehealth visit, but then also their overall experience with the Higgy care manager, were really positive. And so that is always so important to us because being seen as an extension of a patient's primary care team, we want to make sure we're always putting our best foot forward and really not only meeting the expectations of the patient, but same as their primary care provider team, not only meeting those expectations, but we're always trying to exceed them. I won't bore you by reading some of these direct patient comments, but common themes we see is they like having that dedicated care manager who they can give a call to, which is great for the PCP team because we can field kind of those basic questions, give them information, and allow their PCP to move on with their busy day. They like that we coordinate with their doctor so that their trusted PCP knows what's going on. They also share with us that, wow, this really makes me pay more attention to what's going on with my health. It keeps them more aware of the situation. Um, and it find a lot of time it's motivated people. You know, sometimes they've got the wool over their eyes that then when they're seeing these numbers on a daily basis, it's kind of like, okay, I probably should do something about this. So we also will find there's a larger quote down here. Um, we'll find that a patient may be prescribed a medication, but then maybe there's not that time for additional medication checkups. And so by having all of this data, we can share it with the PCP, and the PCP may say, you know what, I really probably should adjust this medication to get where we want to go. So just really great positive feedback from patients who were involved. Every now and again, you know, we might have a patient who's not as pleased. Sometimes we found that I think the one thing that sticks out for me out of the pilot is we had this sweet lady who was going through a lot of back pain. It was hard for her to stand up. So she was frustrated that the scale she had to stand up, you know, to get on. But some of those things are just outside of our control. Overall, we're just really focused on what we can do to benefit the patients. And of course, just like patient feedback is so important, same with provider feedback. We want to make sure that we're constantly evolving to meet the needs of the primary providers because provider buy-in is essential to make RPM work. Um, the patients who had higher levels of engagement and satisfaction were when their PCPs acknowledged the patient's participation in RPM. So either giving them a pat on the back or saying, you know, I saw via your recent report, just making mention and showing kind of that cohesive nature of the RPM program with how the PCP operates. We found that if a PCP does not do that, even if the patient is having a great experience, they very quickly will say, well, if my provider doesn't value this, why should I? And so we'll see their enrollment drop off or their engagement drop off. So demonstrating, having the PCP not only be bought in, but expressing their buy-in to their patients enrolled is really important. And then also, we talked a lot to the care managers, the local care managers at our pilot sites. And the overall consensus from those pilot site organization care managers were that they valued the RPM program because it felt like an extension of their team and allowed for a greater subset of their patient population to receive additional healthcare touch points outside of the patient's regularly scheduled appointments. Um, and so all of that is really encouraging. A lot of providers wanted to grow the program. One thing I do want to call out here when hopefully you read the playbook, I think the lack of bi-directional EHR integration, we did not do an EHR integration as part of the pilot. I think that's one thing to really note that it can be a significant barrier throughout the program flow. So whether it's the transmittance of a referral over to your RPM vendor, if that's the way you go, as well as the RPM vendors sending the the partner organization reports, anything you can do to make that less manual and also make sure that data that's being exchanged is going right to where a provider wants it is going to be super critical for the growth, the scaling of the program, and also the sustainability aspect of it. So I think that's kind of one of the top items that you would want to address with an RPM program. So just want to make sure to shine the spotlight on that piece. Okay, we're at 12:49, just have about 2 or 3 slides left, and then give you all a few minutes back to your day. This pilot would not have been possible without the amazing teams at Helen Newberry Joy, Schoolcraft Memorial Hospital, and Mackenzie Health System. On the screen here, you will see 3 of my favorite people, Allie, Tiger, Heather. Such a kudos to them for welcoming our team into their organizations, finding ways to make this work for their organizations and their patients. Um, I live just in Grand Rapids, but by the end of this, I was thinking, maybe the east side of the state or the UP. Before you know it, I think I'm going to be up in the UP because I fell in love with all of these folks and the extended organizations, and just am so thankful for their time and their energy, and really all they do for their patients. So wanted to make sure if you are seeing them anytime in the near future, to give them a high five because they surely deserve it. So wrapping up, before I leave you today, I wanted to share 2 last items, talking a little bit about best practices and then also about the playbook that we've been working so diligently on. So best practices, I think one thing that you really should do if you're looking to bring RPM into your organization is make sure you have those frontline team members who will be impacted by the program involved in the development and dreaming up of the program from day one. It makes such a big difference in terms of adoption, in terms of thinking of any potential barriers that might be coming down the pipeline. That's huge. For rural friends, we need to address that telehealth intimidation. Huge shout out to the community paramedic program in Sandusky, Michigan, there at Mackenzie Health System. When we came upon patients maybe who didn't have access to internet, or I can't tell you the amount of times we hear from patients, I don't do the internet, or I don't do smartphones. The CPP program, we would arrange for them to stop by the patient's house, help them out for 15, 20 minutes to do that initial telehealth appointment and get them enrolled. We talked about the PCP, verbally closing the loop with the patients, that if you're not closing that loop, you're going to start to lose patients. Easy to use devices. We use cellularly enabled devices. It makes such a difference. There's no app, no Wi-Fi required, especially dealing with senior citizens. I can't believe our device ease of use score was so high, but it's because there are quotes about, anybody can do it. And when you hear that from your 88-year-old friend up north, you think, wow, okay, this is working. Data integration we just talked about, really need that for the scalability and sustainability of your program. And then leveraging underutilized services to bring the program to life. So how I mentioned that the community paramedic program, they had time in their schedule. So Mackenzie Health System said, hey, why don't we team up with our paramedics? And it was a beautiful, beautiful match made in heaven. So all good things to think about. If I were you, I would be very happy never hearing my voice again. I'm so sorry just to share so much information with you during the course of this hour. I hope I didn't bore you to death, but wanted to let you know we have an amazing resource that will be made available in the very near future. So one of our goals, you remember from the pilot, was to document the heck out of everything. And it turned into a labor of love. I was joking with one of my team members members yesterday said, I feel like I'm about ready to give birth to my third child. I'm a little bit anxious. I'm so excited. I want it to happen, but I want to savor the last moments, all of the things. This guide is really meant to help organizations, providers, practice teams think about key issues that may impact the successful launch of an RPM program and really promote some of those things you need to be thinking about way at the front end versus way later on when you think, oh, shoot, I didn't realize those dots would connect. So here, I know this is an eye chart. I should be, I don't know, I guess I should make this into like some sort of recommendation if you need glasses, but here's the table of contents. It is about, I think it's total 80 pages, but it is so much stuff for you to think about, guidance, a lot of in summary pieces talking about ROI. What do you need to contemplate as you're kind of architecting your program? Where the investments need to be made. A lot of don't forgets here, key stakeholders you should be bringing into the mix. So it'll do a deep click into how the pilot worked and then come back to more of that playbook so that you can think about it from your own perspective. Amanda, that's what I've got.
All right. Thanks so much. We have a little bit of time for some questions. So if you have a few, please put them in a chat. And I know Kara would be happy to answer any questions that you have.
Absolutely.
Hmm.
And Amanda, I don't know, I'm not so great on Teams anymore or Zoom anymore because of Teams. Do you mind just putting my email address in the chat just in case if anybody has a question that they're more comfortable asking offline, please go ahead, email me. I'm happy to jump on a quick call. But I definitely would encourage everybody to keep their eyes open for when the Michigan Center for Rural Health makes the playbook accessible to everybody because I think it could really help folks out.
Oh, that is in there. Oh, I have some Q&As. Okay. Uh, I have a thank you. This was a great presentation. And then another one that says, no questions for me. Just wanted to say thank you for the wonderful presentation. This is exciting to hear, exciting work to hear about.
Oh, thank you all so much. That totally made my day. So I hope to hear from you all. If you have any questions, again, there's nothing, Amanda knows that I get pretty pumped up when I get to talk about our partner organizations and share lessons learned. So happy to share any knowledge.
Well, I would just like to end this by saying thank you so much, Kara, for the partnership. It's been an incredible 18 months. I appreciate everything that you've done for not only the Michigan Center for Rural Health, but also the 3 critical access hospitals that we've worked with and the improvements that we've made in the quality of life and the patients that you serve. So thank you so much, Kara. You have been just an absolute joy.
Oh, thank you. All right, you all. I hope you
All
have
right.
a
Thanks,
wonderful rest of
everybody.
your day.
All right. Bye.
Bye.